Hello and welcome everybody. Good morning or good afternoon, wherever you may be in whatever time zone you may be residing. We're going to talk about autoimmune manifestations in the nervous system today, but before I get started, I'll just introduce myself real quick. My name is Dr. Jamie Kunkle. I am a practitioner at Gordon Medical Associates. I mostly deal with complex chronic illnesses. I've been doing that for close to 11 years now. And I'm going to talk about the nervous system today. So that was kind of where some of my original studies started in my undergraduate schooling. So it's a really exciting topic. But we're going to talk about autoimmunity. So let's get rolling. What is autoimmunity? And we're going to talk about that because it can mean a lot of things. Is it, a defined illness? Is there a cause? Is there not a cause? Do we just want to call it autoimmunity for some reason without really even caring if there's a cause? Seen it all. We're going to look at some of the unusual manifestations of autoimmunity in the nervous system. So some signs may be that we should investigate that there could be autoimmune manifestations, and maybe that would help guide our treatments better. We're going to talk about a lot of causative factors and influences for sure, between genetics, predispositions, and infections, toxins, environmental influences, trauma responses, all the usual type of stuff. And then, of course, we're going to do a Q&A at the end. So let's get started. So I'm going to start with just sort of some general definitions of what autoimmunity is defined as here. Loss of recognition of self. So for some reason, your immune system kind of loses sight of what's a danger and what's you, essentially. There are some complex genetics that come into play here, but the epigenetic or environmental influences can really drive this in very unique ways. And we're seeing a lot more autoimmunity these days too. So maybe that's related to environment changing, maybe toxins perhaps, although you can say there's been a lot of trauma in the world lately too, so who knows. Collateral damage or bystander effect. It's kind of like the immune system starts off maybe operating kind of normally, but it's not doing, starts losing sight of what's the problem and what's you, or it sets off almost like a wildfire. If anybody's living in the wildfire spaces, just a little bit of the wrong, situation can lead to a very large inflammatory response. Molecular mimicry, this is very common. An amino acid sequence or like a sequence of proteins within the bug or whatever the substance may be kind of looks like you. So a lot of things look like you actually, because we all live on this earth, so we look like a lot of things and we are very unique, but the immune system doesn't always understand what's you and what's not you. And I gave some examples here. Lyme, the outer surface protein, is one target there. That can look like nervous system tissue or possibly joint or connective tissue and different things. And also strep, is a similar model. Epstein-Barr virus, very common. And then microbiome, it's an emerging area of study. It's not new idea that a lot of disease process starts in the gut, but now we're actually seeing some of the research catching up to that. So you'll hear me talk about microbiome throughout here, and I think I even have a slide later. 3 phases of autoimmunity. This is just sort of general clinical stuff. When the autoimmune response is initiated, people may not have symptoms. It's like, imagine maybe you contract an infection, you don't immediately have an autoimmune condition, or you're living in mold or something bad's happening as far as chemical exposures. There's not an immediate sense that, oh, I have an autoimmune condition. It's not until it hits this propagation phase where the inflammation starts going up and the actual dysregulation of the T cell or the immune system response becomes a little more profound. So that's usually what you catch people is in that proverbial propagation phase. And I wrote some details about this, different parts of the immune system. We'll talk about autoantibodies later a lot, probably, because responses can happen peripherally or somewhere outside of the brain, but then antibodies can then enter into the brain or into the nerves peripherally or centrally, and that can be a problem. And then there's resolution, hopefully, in any autoimmune condition or autoimmune reaction. That's where people may go into remission, things may calm down. That cell danger response model, perhaps there's resolution to be had. But a lot of people that come to me haven't exactly reached resolution, otherwise they probably wouldn't be coming to us. but that's where we hope to get them to. So the gut microbiome, here it is already. There's some talk about the Th17 regulation in the microbiota. That's really cool. If anybody's looked at the whole, T regulatory theories, Th1, Th2, Th17. Molecular mimicry shows up quite a bit here. That's been known for a long time. Certain microbiome in our gut, once again, look like us, either look like our gut, like in inflammatory bowel syndromes, or once again, there can be secondary responses in the lymphocytes. There's a pretty elaborate immune system surrounding the gut that can then signal the rest of the body. So it doesn't have to be, once again, primarily in the nervous system. It may start in the gut and then travel elsewhere. And then here are just some examples of some diagnostics, Clostridium perfringens, Clostridia species, Prevotella, lactobacilli, even some lactobacilli and MS. There's a lot of studies going on in this. So it's important to remember the microbiome does play a role. The gut-brain connections are pretty vast. This is one of them. The barrier function I'll talk about probably later too, because if the gut barrier is not patent, often the blood-brain barrier is not patent. If you want to keep antibodies, toxins, infections out of the brain, barrier function is also a key feature. And that sometimes also starts in the gut. COVID, the elephant in the room as always. So there's been a rise in autoimmune manifestations in the COVID era. Spike protein may have a molecular mimicry sense. It may look like some of our tissues, either in our respiratory tract and cause more extensive lung damage in some of the earlier, long COVID pulmonary syndromes, but also possibly in the brain. So there's been a lot of observations of worsening autoimmune encephalitis following COVID or following COVID vaccination. The common factor is the spike protein, more than likely. So we're still trying to understand this, but clinically we are seeing it. And there's a lot of complex interplay in long COVID, but there's also potentially autoimmune manifestations or a relapse if somebody's in a remissive autoimmune state is also possible. Genetics, I talked about that. This has been studied and there aren't perfect genes to look at to predict autoimmunity in every single person, but you certainly want to think of taking a family history with people and maybe doing some more extensive genetic workup to better understand where the dysregulation is happening in the immune system if you're trying to target immune therapies or address maybe causative or etiologic burdens and stuff. But if you're practicing more of a preventative medicine approach, I think it's important to look at these things a little bit and try to catch them early before they turn into quote unquote autoimmune disorders or that propagation phase where things are very inflammatory. And what about autoimmune encephalitis? I already mentioned that word, but I'd say that the recognition of autoimmune encephalitis and encephalopathies, slightly different nomenclature. It's not super important for this discussion, but autoimmune encephalitis has become more recognized as a syndrome, and neurologists and psychiatrists and other people alike are trying to be informed that this is something we need to be attentive to. So trying not to make too many assumptions about one's acute, even neuropsychiatric manifestations of whatever's going on in their health and their life. So this can be really nondescript things sometimes, like fatigue, cognitive impairment, like I said, behavioral changes or neuropsychiatric symptoms, seizure disorders, movement disorders like tics or other things, Tourette's, other things like this, OCD, autonomic dysregulation, sometimes even POTS or other similar manifestations. Can autoantibodies be functional? This is really interesting to think about. There have been some studies that have suggested that autoimmune manifestations may not always be autoimmune, really. Like antibodies that enter into the nervous system may serve a physiologic function. That being said, they're often triggered by, say, an infection or somebody with immune deficiency where their signaling isn't working correctly, possibly, and even in cancers and other things. So hard to say it's completely normal to have a whole bunch of them. However, their presence alone does not necessarily mean that somebody has a outright autoimmune disorder, if that makes more sense. So they're used to augment signaling, really, is what it comes down to. They may bind to the receptors or some of the surface proteins or influence the communication within the nervous system. So that's kind of an interesting thing that's emerging we don't fully understand. So, what are the common manifestations of autoimmune? Well, there are, by some numbers, they say 30 defined autoimmune disorders of the nervous system, and these could be categorized into myelin disorders, autoimmune encephalitises, um, these meningeal based diseases, brainstem and posterior fossa diseases. These are just all kind of where the autoimmunity happens is sort of where how they categorize them. So it's kind of like where do we need to look for, how are we diagnosing this really honestly? It's based on the patterns that are presenting. It's usually imaging or the presence of antibodies toward a certain nervous system tissue, basically, is what it comes down to. Note in a lot of cases, though, our patients, at least, for example, don't always fit into a lot of these boxes. So just because these are all defined big word illnesses here, it doesn't mean you can't have autoimmune manifestations in the nervous system without a label. So just keep that in mind. And also, it's important to note that proverbial peripheral or other parts of the body inflammation may end up influencing the brain or the peripheral nerves, causing neuropathy or other things like this. And you'll see that with rheumatoid arthritis and lupus, sarcoidosis, things that may start peripherally, or Behçet's here is one to consider. Thyroiditis, like Hashimoto's, can have encephalopathies or encephalitis type responses as well. So it's important to note that this list is not exhaustive by any means. Also, overlooked autoimmune presentations. So you'd think at this point we wouldn't be saying acute neuropsychiatric disturbances, but people are still making a lot of assumptions about those, especially in the conventional realm. When I first started practicing, I think pandas and these things I'll talk about a little bit were just emerging. But there's still to this day a lot of controversy about whether those things exist or not. And people like to still separate out psychiatry from physiologic or physical illness. It is possible to have diagnoses and pathologies on the full spectrum of that plane. But just so you know, acute neuropsychiatric disturbances should be suspicious. Movement disorders, it's not just seizures. Sometimes there are these pseudo seizure disorders. I've seen a couple stiff person syndrome patients in my practice where they kind of seize up and they either stop talking mid-sentence and can't talk. I think Celine Dion, maybe one of the celebrities, was just diagnosed with this recently. May have some COVID contributions to it as well. And just because somebody has a seizure doesn't, you may want to look at the physiologic influences of that, especially if they have an acute seizure. They never had one early childhood or otherwise, and suddenly they present with a seizure. That's really suspicious, isn't it? Dysautonomia, I mean, POTS has sometimes autoimmune antibodies that are associated. You can measure that on certain labs. There's a German lab, I think, called Celltrend that measures that, for example. But also, you can see people with blood pressure and heart rate fluctuations, even high heart rate or low heart rate, can be associated with certain antibodies. This NMDA-R, which is a glutamate receptor antibody, is pretty common these days and sometimes in younger folks. So you'll see autonomic dysregulation, but there's not an immediate sense that this is autoimmune manifestation. And other things like constipation, abnormal sweating, it doesn't seem, my first thought is, hey, this is an autoimmune disorder. Pain, yeah, it's possible. It's possible one's perception of pain or their peripheral pain disorders, things that they've even been called fibromyalgia or other stuff like this. People are really sensitive to touch oftentimes. Could be a manifestation of autoimmune encephalopathies, encephalitis. Hyperexcitation of the peripheral nerves, that can certainly cause neuropathies or tightening of the muscles, abnormal movements, fasciculations, tremoring type responses, cramping, all this type of stuff. Yeah, unpleasant senses of touch, people having more itching throughout their body, because itching can be a neuropathy sign too, weirdly enough. Gut, yeah. So I mentioned the gut contributions before, but if somebody has a really erect gut in neurologic symptoms or some nondescript neurologic symptoms, that could be a sign. It's just really not specific. And I mentioned the thyroid too, whether it be the antibodies associated with Hashimoto's affecting the brain, maybe some of them, or maybe there's some associated antibody responses to whatever the trigger is, or simply just not having adequate thyroid in your brain is usually not very good for nervous system regulation. So that should be considered too. Okay. And then I just put a little thing here about manifestations in different phases of life. When you're a kid, you don't have as many controls over your emotions. So if you have a lot of inflammation in your brain, you may have some pretty intensive involuntary uh, compulsions, fears, phobias, anxieties, behaviors, unimpeded, repetitive behaviors, different things like this. You may see this manifesting sometimes in autism spectrum disorders or PANS, PANDAS, OCD, like I said, tics before, TICS, tics, Tourette's, all that kind of thing. In the young adult, it's more likely to see a lot of hormone dysregulation, especially as people are going into puberty and even into their early 20s when they're supposed to kind of have a peak reproductive function. It's a possibility that they'll have dysregulation in some of those hormones, either primarily or secondarily, meaning sometimes affecting the gonadal organs themselves, some of these antibodies or some of these responses, but also in the hypothalamic pituitary axis, that central computer that regulates um, their hormone functions across their body, so including their thyroid and their testicular or ovarian function. Adults, a lot of fatigue, brain fog. There can still be a lot of neuropsychiatric manifestations, generally speaking. Elderly, more severe cognitive impairment, maybe more dementia or early cognitive changes that are kind of like dementia. Possible seizure disorders are common in some of the later onset autoimmune encephalopathy syndromes in elderly. And you'll see that with kids and people of all ages too. And all ages will have a tendency to experience some kind of autonomic dysregulation. So dysautonomia needs to be looked at in all people. Managing controversial diagnoses. I just put a slide about this because it comes up quite a bit and I've already sort of alluded to it. These are just a few reminders that if you're investigating or you've been diagnosed with, say, autoimmune encephalitis, and that's manifesting as some kind of neuropsychiatric syndrome, let's just say, you're going to get a lot of pushback sometimes because people want to kind of fit you into an easier box than that. If you're saying that there's a physiologic influence to your illness, that kind of throws a whole cog in the like, I just, the traditional model of I'm going to diagnose you, I'm going to put you through extensive psych testing, I'm going to give you those five axis or whatever it is, the axis diagnostic system of psychiatric illnesses, and then we're going to medicate you or we're going to put you into therapy or something like that. But if somebody has a physiologic illness that's supposed to be on that access system, honestly, is rule out medical causes. Does the person have hypothyroidism? Do they have an acute encephalitis event or something like that? It gets missed a lot though, and people do get gaslighted a lot as a result of this. They get told that it is just a pure psychiatric illness. This is all in their head. And sometimes they know, and most of the time they do. You have to trust that patient that they do know deep in their body, they know, they have the awareness that they do have a physical issue and they'll tell you that. But a lot of people will be like, no, you're just crazy, or you're just this, or you're just that. So let's just, as practitioners too, if any practitioners are listening, try not to compound the medical trauma on top of their probably pre-existing trauma that may have predisposed them to the autoimmunity to begin with. Let's try to be a little bit more careful about labeling so quickly, because psych diagnoses also stay with you for the rest of your life, especially when you're diagnosed with a personality disorder. That's not considered curable. Therefore, once you are of that persuasion, it becomes more difficult sometimes to get the actual physiologic or physical help that you need, because now you're at the top of your chart, you're labeled this, this, and this. So anyway, I just put a plug in for that. There's more on that conversation. Maybe I'll talk about sometime. So how do you approach autoimmunity, generally speaking? Well, if you can find it early enough that there's autoimmune manifestations, or it's leaning toward that, or somebody's susceptible, or they have a strong family history, or there's something weird and unusual about the inflammatory response that's happening, and you get a feel for these things that's not right. It's not responding to treatment in quite the same way that I had hoped. But if you can, try to find the culprit, early on, maybe in that initiation phase, if it's starting to go into that propagation or where the fire is starting to go off. If you find the infection early, treat it. If you find out that person's living in mold or there's a lot of toxins in their life, then deal with that. If their gut's not doing too well, work with that too. If they just got like a food poisoning event and they're looking like they're going toward IBD or even whatever encephalopathy, work on it early. That's all. Stress. I just wanted to put a little plug in here because I've mentioned trauma and other things, but stress has been well documented to influence the immune system. So there's actually a lot of data on that, and you can read through this. But I believe it was studied with MS here and other things, and even just the release of cortisol and some of these neuropeptides can activate the glial cells in the brain and can potentiate these inflammatory responses. And you'll hear a lot of people before they develop autoimmunity, there's some kind of stressor that they went through in their life. And those they don't have to always be like, oh, I was working too hard or I had a death in the family. It could be something like pregnancy too. Like there's a constitutional shift in the process of pregnancy. There's a lot of shifts and changes in the signaling system and the hormones, in the mobilization of toxins. There's 1,000 things there. And a surgery, like even much the same, a big injury to the system, those things can lead to flare states. And they even found that EBV antibody levels were correlated with early life stressors. So people that had less of those had less high EBV antibodies than those that had more early life stressors. So for whatever that's worth, the regulation of some of these common viruses we all get exposed to in the course of our life can be negatively influenced by stress. Well, surprise, surprise, it's a herpes virus, and we all know cold sores and stress and all that kind of thing. So it's not much different with EBV, but it's not much different with other infections, is it? CRP markers, kind of other things you can monitor. So some philosophy here for supporting autoimmunity. What part of the immune system needs to be supported? Yeah, I mean, a lot of this has like autoantibodies. You can run those through many different labs, like Cunningham panel or Vibrance Neural Zoomer possibly, or the Cell Trend from Germany, or like even through LabCorp requests, GAD65, NMDAR, whatever. So try to quantify that. Also, you can run lymphocyte panels and other more extensive, innate immune system testing. So there's those two parts of your immune system you want to look at because both of them usually aren't functioning right. I look at blood-brain barrier and gut barrier function a lot for those reasons I mentioned. Trying to keep some of the inflammatory junk out of there is a good idea. And if you're talking about antibodies, you want to kind of try to mitigate much of the passage into the central nervous system. And on that end too, I don't know if I made mention in here, but the sinuses and the upper airways is a very close contact point to the nervous system, or even the teeth if people have dental infections or root canal cavitations, whatever, any of those things. The proximity effect can happen, but there can also be antibodies created from anywhere in the space that can easily enter into the nervous system through different means. But there's not much of a barrier at the apex of your nose and that little tiny plate, the cribriform plate there, where the olfactory, the smelling nerves dive in. So there's a lot of mechanical susceptibilities there. That one doesn't have a big barrier around it, that particular nerve. Working on the microbiome all the way around, gut, brain, sinuses, upper mouth, oral, whatever. Work on all of it if you can. Find out if there's an imbalance in one of those areas that's clearly caused, especially if it's causing symptoms, don't listen to that and try to improve upon it, even if it's kind of subtle. I have stuffy noses all the time, but I also have severe brain fog. Maybe there's a connection there. I don't know. I already mentioned about identifying and treating trauma responses, PTSD. I mean, you don't have to do all this yourself as a practitioner. That's where you might have some other team members that are a little more conscious of that. That's completely okay. But just understanding that it may play a role in these illnesses. Structural stuff, I've said this before in other talks, but it is important to understand people with autoimmunity can develop or be more predisposed to structural imbalances and deficits through multiple different means. If they're genetically hypermobile or EDS or whatever, they're more prone to autoimmunity genetically usually. Those autoimmune reactions can go towards that connective tissue, further destabilize them. They get a trauma physically on top of that, possibly end up with craniocervical instability or intracranial pressure, tethered cord type syndromes. There's a lot of those. So don't forget the structural pieces that can manifest or be maybe an effect of the autoimmune manifestations too, but also can keep them from getting better quite a bit. Let's see. So yeah, and just associated inflammatory responses, we usually look at mast cell and look at other ways we can support that system to keep it from getting overstressed and overstrained. Autonomic dysregulation, psychiatric therapies of different sorts, chronic pain, poor sleep, all of it. So the usual types of things, right? Diet's in here too, of course. I listed a few things that may be worth looking at. There's these autoimmune diets. There's keto in some people. It's a medical diet. It should probably be supervised, but some people do really well with it in the nervous system. Gluten doesn't seem to do well with a lot of people, at least in this country. Uh, and yeah, there's these other endotoxins or other toxicants in the foods that can sometimes be triggering the brain that we would look at. Histamines, oxalates, sulfites are just a few examples. There are others too, lectins, I believe. So I might use desensitization therapies as well. I think I like doing low dose immunotherapy especially if there's like a molecular mimicry thing going on, or if I have a sense that that is, I'll use that to try to calm down the regulatory cells of the lymphocyte system and see if that translates over time. Might help, especially if you've kind of stabilized people and have done some of the hard work already, and they're still not completely regulating. There's the usual stuff like low dose naltrexone. There's a whole wide world of peptide therapies that can affect the brain, affect the T cells, affect the nervous system. Low doses of rapamycin can help T regulatory function in some people. I just listed that there. And then other therapies that kind of work on those theories of Th1, Th2, Th17 balance. And I mentioned how microbiome has a big modulatory role with a lot of this too. And then some other emerging therapies like photodynamic therapies, red light, and many others. I think even methylene blue would be considered a little bit in that realm. Its blueness is quite interesting. And there's many other things in that world that I'm still learning. Trauma support I've already mentioned. I just listed out stuff actually here, and finding places where that trauma is stored in the system. That might be some of the structural work that one might want to do. Somatic work, different things like this. I like some of the functional and neurologic testing out there, QEEG, SPECT, possibly, like the Amen clinics do that. Functional MRIs of different sorts, neuroquant sometimes, if they're consistent. There's a lot of stuff you can look at and see how that's manifesting in the brain, how it's not regulating, and then maybe you do brain retraining stuff, and that helps the system calm those stress cycles, get out of that fight or flight response, and their system is much more likely to heal if you address that appropriately. I've said that before, and I'll say it again. And then there are some new or emerging therapies like ketamine-assisted therapy, for example, things that induce neuroplasticity or sort of shift the connection points in the brain and hopefully try to reboot a little bit and try to get out of a stuck response in the brain itself, and maybe reducing inflammation too in some cases. I mentioned structural work. Higher force interventions. I'll say a few things about this, and people may have questions about these too, honestly, because it comes up quite a bit. Because if you're chronically ill and you've done all the usual stuff, you've tried to treat the infections, you've tried to detox, you've changed your diet, you've seen 10 doctors, I don't know, 10 dietitians, I don't know. Sometimes you may need some of these therapies. Maybe you put it off initially because I didn't want to do this big crazy stuff and toxicities to the system or whatever. But if the system really is truly stuck in that danger response and you've tried a lot of stuff, I think you can theoretically reset it with some of these therapies. Sometimes they are a necessity if somebody is in a really dangerous space with the autoimmunity. So that's where you might see your biologic agents come in during the acute phase of that. Like if you're having a mega MS flare, that's probably not good. If steroids aren't working, people use a lot of the biologics target those B cell systems, the ones that produce the autoantibodies, and try to knock them out. IVIG is a classic. I'd say with IVIGs, definitely be cautious if they're currently have an active infection that you didn't, or you don't feel confident you treated it very well, possibly. Low doses of IG, if somebody has, like, say, an immune deficiency, like CVID or CVID, chronic variable immune deficiency, low doses may enhance their immunity, but that may also flare them. That might also like kind of create almost like a herpes response if their immune system wasn't really handling those infections really well to begin with. Suddenly you're getting donor immunoglobulins from everybody and their mom, and now, bam, you know. So you got to be careful with that. And then really high doses of IG has other side effect potentials, but the really high doses may knock out or drown out those autoimmune signals on multiple different parts of the body. So directly on the cells and their migrations, the mast cells and their activations and other things. So time and place, plasmapheresis or full plasma exchange, also known as apheresis, that takes out all those antibodies over a period of like 4 to 6 treatments. And timing is sort of key with some of these too. It's a really good theoretical reset, and it does work sometimes, but I'd be cautious like rushing into it if you haven't exhausted your other efforts. But we've guided people through plasmapheresis, and there are protocols where you can theoretically treat the infections either before or during the procedure. You can use small doses of IG to replete some of the lost good immunoglobulins that may be lost, so you're not leaving the system open to flaring. And you can pre-detox people because you will get toxin mobilization when you're moving the plasma like this. And as I mentioned, you'll get sort of like this phasic response where you're filtering a lot of stuff out, but then you're moving things out of the blood first, and then you're moving things out of the tissue, and then you're mobilizing toxins and other things, and it's like it can be shaky over those first 1 to 3 usually. So, and downstream inflammation regulation, it stands to reason if even if somebody doesn't have a true mast cell activation, if their mast cells are really overly triggered by these antibodies for some reason, and you haven't found other solutions, you could probably use stronger agents to try to at least augment the inflammatory response and stop the fire a little bit, improve the quality of life, or prevent sort of a negative cycling wildfire type reaction that could be happening with the mast cell even as well. So yeah, that was about 30 minutes of me blasting through 30 slides about a very complicated topic. So now I want to hear from all of you guys about what you would like to talk about that I didn't talk about or clarify.
Thanks, Dr. Kunkle. Okay, so the first question is, do you consider fibromyalgia an autoimmune disease, and how can we test?
Not really. I mean, just think of it this way, not by nature, but fibromyalgia is a syndrome diagnosis. So what that means is it's just a set of signs and symptoms that come together, and they just call it fibromyalgia. So this is very common with even autoimmune conditions. They just call it MS. But think about it a little bit further, due to what? So if this is a fibromyalgia presentation, could it possibly have a peripheral nerve hyperexcitability due to autoimmunity? Maybe. And I'm just saying, don't put all fibromyalgia in the same box. Just like don't put all chronic fatigue in the same box. And I'll say that again and again.
We have a question on that, so you might want to just reiterate where someone is asking about, would you guess that someone with decades of ME/CFS has an autoimmune situation?
In some circumstances, they do have evidence of that, especially if it's been going on that long despite therapy and treatment. I mean, it is possible maybe the treatment wasn't effective for some reason, but you do have to look at whether there are possible stock autoimmune manifestations, and maybe there are some other ways you can manipulate them, kind of understanding the science and also where they're affecting the brain or where they're affecting the nerves. So as you can see, fatigue is the most nondescript symptom ever, and it spans across a vast range of medicine and medical, because it could be fatigue due to cancer. It's like, who knows? So
Unmute myself. Okay, I'm a 66-year-old female and have shingles for 2.5 months. The symptoms subside and then reemerge. Lesions have been on both sides of my body, from my coccyx to my neck. I have ongoing burning skin sensation and infrequent jolts of pain. I'm wondering if you can offer any suggestions on what she can do to calm the nervous system.
wow, yeah. So I'm sorry you're experiencing that. That sounds like a pretty severe manifestation of shingles. I would certainly be wanting to look at your immune system and why it got hit that hard. Honestly, there's probably a history there I would have to look at. I would usually treat that fairly aggressively if it's relapsing with antivirals, and I would use appropriated anti-inflammatories and other symptomatic pain support therapies to assure you're able to sleep and have very basic foundational healing potential with those things. But I would have to investigate much further with you as an individual what the causes of that may be, because that's, yeah, a little unusual to have it that bad.
Can autoimmune encephalitis look like a severe hemiplegia migraine, like a stroke?
Possibly. Um, I'd say in general, migraine certainly can be a manifestation that maybe I didn't mention of encephalitis. I mean, migraines are sort of like unofficial seizure type activity as it stands, that they're abnormal signaling in the brain that kind of gets overloaded. So, and I mentioned seizure disorders being sort of a factor or feature. So it's not completely, it's not always that, but you might want to look at autoantibodies in that case if it's a relapsing condition that's really stubborn and not responsive to typical treatments, especially.
What are your thoughts on prolactinoma induced changes in the HPA axis as a trigger to dysautonomia, even if on a microscopic level?
Oh yeah, prolactinomas, like true prolactinomas, like diagnosed through imaging, not just high prolactin. Because I mean, I've seen a lot of patients with high prolactin for a variety of reasons with neuroinflammatory conditions, but if we image them, I don't see the actual, mass structure there. However, I had at least one or two patients that we treated the high prolactin with, basic drug therapy, and it really did improve their neural regulation quite a bit. Whether it's affecting their HPA, I'm sure it is. And whether it's affecting their sex hormones, probably. It's more obvious sometimes in women than men, but it's pretty obvious in men. Still much the same. So higher levels of prolactin are known to cause sex hormone dysregulation and imbalances, and influencing FSH and LH stimulation to the testes or to the ovaries. So yeah, it influences a lot. I always run prolactin. I always do.
Great. How can a person be checked to see if their autism is related to an immune disorder?
Yeah, that's a good question. I mean, I think once again, it's probably good if proper evaluation could be done early in this case, and see. I think some people run very basic stuff. Like I was just at a conference a few weeks ago, and they were running just high sensitivity CRPs in these kids, and C-reactive protein, but it has to be the high sensitivity variety, and you can see if they kind of have a subtle level there. That's just a simple, like, sort of single test option. But otherwise, I mean, it's a lot of different things. Once again, it can be looking at their gut, like doing a stool test and looking at inflammatory markers in that region. It can be running autoantibodies, although sometimes in very early childhood those may not be as obvious. But yeah, I'd say I think in really, really early childhood, people start with the basics in terms of the CRPs. I think that's one thing I remembered.
Do you know any autoimmune connection with lifelong low muscle tone? Any other ideas of causes?
Yeah, I mean, I think those peripheral neuropathies sometimes could cause that, but there are also these autoimmune, like myositis, or autoimmune neuromuscular disorders out there. They do exist. Most people don't run the antibodies for them either, because they're not always like classic anti-nuclear antibodies that you would see on a typical panel. So they might be worth looking into a little bit further. But I would also check genetics, like mitochondrial related metabolic disorders and different things like this too. If it's been lifelong like that, I would almost guess that there's a genetic component to it, and it probably just hasn't been found.
Great. Do you often see a link with toxins or infections and elevated thyroglobulin antibodies? And this person said 400s.
Thyroglobulin specifically, and say the question again. It was thyroglobulin.
Do you often see a link with toxins or infections in elevated thyroglobulin?
Oh, yeah, totally. Yeah, I mean, thyroiditis of any variety is almost always one of the two or both of them. I mean, it's like I've very rarely seen somebody with any kind of thyroiditis that didn't have some kind of infection induction. I mean, there's a lot of Epstein-Barr virus type things, of course, but the thyroid is a big, giant circulation. It has to sort of give thyroid to the whole body. So a lot of stuff goes through there. So you better bet toxins will enter that system, and you better bet infections will enter that system. And that's probably how it gets triggered.
Dr. Parpia often says that someone can have both an overactive and underactive immune system. Does that happen at the same time, or does it switch back and forth? How does this work?
Oh, yeah, totally. I mean, that's a really good question. And I will say that whenever let's just say you do have a patient come in and they say, I have an autoimmune condition, and you run a lot of these panels, you're going to see that a lot of times. A lot of people walk around with like low white blood cell counts and stuff like this. And so there's a lot of different mechanisms in that, because one thing for certain is that if somebody has classic CVID, like CVID, they can actually be more prone to autoimmunity. So whenever the normal regulatory systems of dealing with, forming natural immunity appropriately and being able to like quickly identify those things if you see them again and mount a normal immune response, if that machinery is not working right, the immune system can very easily become confused. And I've also seen this with like complement deficiencies and this kind of thing. So those are sort of genetic, right? So there's the genetic immune deficiencies, and then there is whenever the immune system becomes dysregulated through these complex processes, it can become under responsive to normal immune function toward it may be in the T regulatory system mostly, it's maybe in the innate immune system here, but sometimes it is because the B cell system's not getting signaled properly and the antibodies are all over the dang place. So there's a lot of complex interplay with this immunology, but you will see that as an acquired issue once again. So those people may not get quote unquote sick in the same way a normal person would because they don't have symptoms, but at the same time, they'll have this prolonged flare of their autoimmune manifestations, and they don't clear that stuff normally. So they don't fever normally or mount normal immune responses. So that's a loaded question, but hopefully that gave you a little bit of a glimpse of the complexity of it. But yes, we do see that clinically, though. Yes, absolutely.
What panel for autoimmune antibodies do you like to run?
Well, I mean, I'll tell you, the ones on LabCorp or Quest aren't that great, but I do run them if I'm running things through insurance. I don't catch them very often, the exception being GAD65 and NMDAR. That reset those ones are the most common I would see. So I'll run Cunningham's, of course, on kids, but I do run Cunningham's on adults too, because they do have some validity in adults too now. They're not just for kids. They just have to do with a certain 5 arrangement of antibodies that have been pretty well studied for encephalitis, and usually in the brainstem or the basal ganglia area. And if they're really freaking high, that's probably diagnostic. And then the other one is the Neurozoomer Plus is useful from Vibrant. I think that one's an inexpensive option comparatively to the Cunningham. And then there's the Cell Trend from Germany. Those are just the ones off the top of my head, and I'm sure there are more.
Can you talk a little bit about your favorite peptides in treating autoimmune disease?
Sure. I'd say the simplest and probably least reactive first would be the TB4 frag or the thymosin beta 4 even, but the frag doesn't stimulate the mast cells as they say. But that's modulating microglial or like the immune system helper cells of the nervous system, and it doesn't seem to like overstimulate the immune system at the same time. And I've seen that thymosin alpha can be okay there too, but beta is way safer option usually whenever you're starting out. And then BPC 157. And that may be because of some of the barrier support that it has. It seems to help gut and blood-brain barrier function and tends to improve like, cognitive function in some people. It has some modulation in the liver, but those are the gentlest two probably that I would get started on. And then from there, it's kind of figuring out what that individual person really needs with the peptides and what signals you're trying to influence, because you can get to the bigger stuff like cerebral lysin later, or things that are really going to augment plasticity, but plasticity doesn't do as well whenever you're really inflamed. So you want to kind of start with the inflammation modulating peptides, and those are the two that are the most well tolerated, and there are more, but those are the two.
Great. Have you seen hemp products like CBD trigger an autoimmune response? If yes, what would the mechanism be for this?
Interesting. I will tell you that there's some research going on out there on IV CBD, and I will tell you that will absolutely trigger a response in a lot of people, at least a lot of my patients, because CBD in an IV form has a lot of like antimicrobial, possibly biofilm modulating, but probably also just the fact you're concentrating a massive amount of drug into a IV. As far as for oral arrangements, I mean, there's multiple mechanisms that could be had there. I mean, anybody can react to any given substance because of their immune intolerance, and that could be because of the mast cells or because of the T cells or who knows. So somebody could get triggered through those means. Otherwise, it probably I don't know if I could tell you a complete mechanism there. But it would really be something I'd have to look into. But CBD does create a lot of different varieties of immune modulation, and probably if that person genetically, their SNPs or whatever it may be in their genetics are not favorable for some of that modulation, it may be pushing things in the wrong direction. So I know plenty of people that can't tolerate curcumin either, that it can flare them, and it can also be a detox agent and other things. So more often than not, there's more than one mechanism with each of these things, especially from the plant world, and then there's a lot of individual genetic interplay.
How do you treat infections when there's a potential autoimmune involvement?
Well, for one, if they've already developed the autoimmune manifestations and they're pretty severe, you want to be careful just rushing into treating the infection if it's kind of more chronic. So usually you'll want to approach it with inflammation modulating agents first and try to get their immune system under better regulation. And even like if you, let's just say you were treating like Borrelia or whatever, Bartonella or something like that. Even if you're using traditional antibiotics, you would use agents first in a lower amount that have a potential to reduce the inflammation in the brain and have a potential to have like a rheumatic or auto-inflammatory influence in a positive way. So you might use like minocycline, fat soluble, low dose, kind of lower inflammation. You might use hydroxychloroquine in some cases because that lowers inflammation in the brain. Uh, you might use stuff like that, stuff that's not going to suppress the immune system function, but can bring the fire down a little bit. And there's 1,000 other things. That was just a quick model, but I would try to get the inflammation down first.
Would the lack of antibodies in the cerebral spinal fluid necessarily mean that the patient does not have an autoimmune issue impacting the brain and neurological system?
Yeah, I mean, I think spinal taps and CSF evaluations are not the end all for diagnosing these things for sure. I think, like I said, that these antibodies are mostly created peripherally or outside of the central nervous system. And there may be reasons why their entry into the nervous system may fluctuate from time to time, barrier function or flaring of primary infection or autoimmunity or stress response or whatever. So you catch it on a not obvious day, it might not be there. Or maybe they just didn't measure the right antibody, because so yeah, CSF analysis has notoriously been a little bit, cerebral spinal fluid analysis has been notoriously a little bit shaky for trying to really be clearly diagnostic here.
Assuming someone has already made the lifestyle changes that you've covered, are there any supplements that would be reasonably likely to reduce the neurological symptoms, regardless of the underlying issue, especially like brain fog?
Oh, well, I mean, there's just supplements that reduce neural inflammation or sort of modulate immune system function up in the brain. I mean, that's your curcumin and your resveratrol and your EGCG and your luteolin and your there's a whole bunch of them that can be helpful in that manner. So usually at Boswellia, I mentioned that one already. Usually I'll try to find what makes the most sense for those people, particularly. And once again, if there's a constitutional like mast cell disorder or that sort of screaming out at us, we're gonna do a lot of stuff in that arena too, or put them on lower histamine for a little bit, or figure out sort of what the they of it really is. So yeah, and then there's a whole bunch of herbal medicine, of course, too, that can help the brain as well. Like Japanese knotweed kind of is a resveratrol application, or Chinese skullcap root has bicolin flavonoids and different things in it. I mean, there's a ton of stuff out there for sure.
What are some of the therapies for Th1, Th2, and Th17 balancing?
Well, I mentioned how Th17 seems to be influenced by the microbiome to a great degree. Also allergy syndromes and kind of maybe some mast cell orientation over in that arena. Th1, Th2, I mean, there's some systems that have sort of been loosely established to regulate that. Like certain herbs may fit into a certain category. Like I think astragalus for Th1 or berberine for Th2. There's Th2 is kind of like more cellular immunity function. Um, but when it goes wrong, so this is a complicated subject because really it's kind of a balancing act. It's kind of an ever-moving sort of motion with these different systems. So just saying in that day, in that moment in time, even if you measure all this stuff, that this is exactly what you want to do or this is exactly what's appropriate, you still kind of hit these barriers of like, what's the reality, you know? So things that modulate are probably most effective in those arenas, and those are maybe some of your broad modulators and a lot of your herbal medicines and stuff like this. So you'll find breakdowns of that. I believe there's that guy, Dr. Yannick, he's a chiropractor. He has this cogence system through Purin caps or something like that. Anyway, he breaks down a lot of like, these are the nutrients for the TH1, the TH2, and the TH17. So